Unit 1, Part 3. Low Cost Benefit Options, or also referred to as LCBO. With growing concerns for the affordability of medical schemes to low-income families, the CMS introduced the concept of LCBO within the medical schemes environment in February 2015. Subsequently, the CMS engaged with key industry stakeholders to get inputs and recommendations on the futures of a potential LCBO, or otherwise low cost benefit framework, the low cost benefit option framework, including benefit package, pricing, etc. The objective for establishing LCBO within the medical schemes environment is to expand medical scheme cover to the formerly employed that are not already covered by medical schemes. It is also hoped that drawing more people into the private health sector will lower the burden on the public health system. The CMS also seeks to meet the demand for health insurance that is currently being met by alternative insurance offerings such as hospital cash plans, primary healthcare insurance, and gap cover. The LCBO will ensure appropriate benefits for this target market and will also ensure that quality cover is provided. Following consultations with stakeholders and inputs from subject matter experts, the CMS has developed an initial LCBO framework guide on the basis for which medical schemes can submit proposals for LCBOs. These also guide further refinement of the proposed LCBO package and structure. Broad principles guiding the development of the LCBO are outlined as follows. Protecting risk pooling. The existing medical scheme risk pool should not be undermined or fragmented. In other words, they must leave it as it is. B. Benefit design. Proposed LCBO framework envisages a possible departure from the current requirement of PMB if an exceptional circumstance is demonstrated and that the proposed benefits in LCBO are based on affordability of the intended target market, cost-effective and evidence-based healthcare provision, and responsiveness to market preferences. The framework intends to maintain the content and objective behind PMBs to the extent to which affordability is not compromised. So they must look at all those things, but they mustn't compromise the affordability. So they must keep the prices low and keep it affordable. C. Continuation of care. The LCBO framework should ensure the continuation of care in a setting that may be out of network, as these products are typically developed based on contracted networks of primary healthcare providers. So for instance, normally they make use of the a group of medical doctors, like how can I say, now I can't think of healthcare providers. It's a group. I've got the name, but yeah, in any case, it's a group of healthcare. Let's say, for instance, Specsavers. They will tell you must make use of any Specsavers. But now your optometrist is not part of Specsavers; they are on their own. So they want them to look at those kinds of guys, that you don't have to go to Specsavers, that you can go to somebody else. All right. Like Mediclinics as well. Yeah, the Mediclinic networks as well. The same thing. So solvency protection, that's number D. The statutory solvency requirement of the MSA should be maintained, as this is to protect the financial integrity of a scheme. An application for an LCBO that requires an exemption from the statutory requirement may not be under the proposed framework. So they don't want you to have any exemptions from the LCBO. Non-health expenditure, NHE. In evaluating the value proposition of any suggested product, the affordability of the proposed contribution must also ensure that the level of the NHE, the non-health expenditure, brought to a proportionate level to ensure that the benefits provided are optimized. So give them as much as possible benefits under the low-cost benefit options. F, marketing. The framework envisages the granting of exemptions subject to certain conditions and defined terms for the operation of the LCBOs. The purpose of the framework is to expand coverage to the persons that have not been members of a medical scheme previously, referred to as previously uncovered market. It is important to ensure that in the marketing of the LCBOs, it should be targeted at the previously uncovered market and that they are not misled into believing they are purchasing a more comprehensive product. That is the case. G, underwriting. Late joiner penalties should not be applied. The very rationale for exemptions is that these people have been excluded from risk pooling opportunities, not by voluntary risk selection, but instead by economic disadvantage. So you cannot discriminate against them and penalize them with late joiner penalties because they just could not afford medical aid, not by choice, but by salary income. And you know what late joiner penalties is, or if not, we'll get to that discussion a bit later. H, the framework provides for the opportunity to be responsive to the needs of the environment while at the same time wishes to ensure that the policy objectives of open enrollment, community rating, consumer protection, non-discrimination and expanding risk pooling objectives are demonstrably furthered with each exemption. Following further stakeholder engagement, the CMS provided additional guidelines to medical schemes and other entities interested in establishing the LCBO. It will include a mandatory minimum set of benefits geared towards preventative and primary health care, management of acute conditions, and a limited set of chronic conditions. Also, a list of mandatory essential drugs, pathology tests, dental procedures, road transport, and a limited chronic condition must be included as part of the benefits offering. For cost effectiveness, the LCBO is to be delivered through a network arrangement. Also, the public health system cannot be the default network provider. So you cannot send them to the public health system as their network provider. Okay, then medical schemes interested in offering LCBO would need to apply for an exemption from the FSCA of 1998, the Medical Schemes Act, especially as it applies to open enrollment, PMBs, and broker remuneration, broker commission in other words. Only those below a specific income limit below the tax threshold will be eligible for membership. Also, this option may not be available for buy down for those already members of medical schemes. To minimize the cost of this option, broker fees have been capped to an upper limit well below the limit for standard medical schemes options, in line with the stipulations of the MSA. However, schemes can apply for an exemption to amend the remuneration of brokers. Brokers want their commission for selling these products, and therefore you have to negotiate the remuneration and commission to the brokers. LCBO will be restricted to employer groups with a minimum of 15 employees during the first year of inception, and after that, the principle of open enrollment will apply. Medical schemes will not impose any co-payment for services covered under the LCBO. So they cannot charge those people to pay extra. Healthcare provided will be remunerated at 100% of the negotiated tariff for services rendered. In other words, they must pay the full price. LCBO will be delivered through network arrangements for cost effectiveness. Industry stakeholders such as medical schemes, administrators, managed health organizations, and health providers have had an opportunity to review CMS pronouncement 1 establishing an LCBO, that was in Circular 9, and proposals for the structure and features of LCBOs, that was in Circular 37 of the CMS report to inform exemption applications. Most stakeholders are in favor of increasing access to low-income households, the idea of introducing a low-cost option, and increasing the number of medical scheme members. However, concerns have been expressed around some aspects of the LCBO proposal. And these are mainly around 1. Considerations for the longer-term health sector policy agenda in South Africa. Some stakeholders sought clarification around how the establishment of an LCBO fits into the overall long-term reform for the funding environment. The NHI proposal anticipates a diminished role for medical schemes from providing duplicate cover to providing complementary cover. 2. Potential for further exacerbation of an already fragmented medical scheme industry. A common concern from most stakeholders was that the introduction of LCBO in the medical schemes industry would exacerbate fragmentation and compromise the sustainability of current risk pools. Sorry for that tongue twister. Number 3, revision of PMBs as an alternative option. Some stakeholders suggested a revision of the PMBs to focus less on hospital-based catastrophic care, but on primary health care. Some stakeholders suggested that the introduction of low-cost PMB rather than a low-cost benefit option that is separate from the other medical schemes options. Those who want a more generous cover can then opt for higher benefit options. And 4, other suggestions by stakeholders include recommendations on areas such as solvency ratios, eligibility criteria, underwriting, and brokerage fees. So what is the current health policy context, the burden of health disease in South Africa? South Africa has a quadruple burden of disease with a high prevalence of HIV/AIDS and TB, tuberculosis, high maternal and child mortality, high levels of violence and injuries, and a growing burden of non-communicable diseases, NCDs. In 2018, the leading cause of death was tuberculosis, which accounted for 6.5% of all deaths, followed by diabetes with 5.5%. Of note is the number of NCDs in the top 10 causes of deaths, which together account for approximately 23% of deaths, more than half of all top 10 causes put together. Over the last 10 years, South Africa has been seen the number of people with non-communicable diseases, NCDs, increase to the point where the numbers are higher than those suffering from communicable diseases. Today, South Africa have a 50.9%, a 51.9% chance of dying from an NCD, diabetes, heart disease, and stroke being the most likely culprits, according to the NCD countdown of 2030. South Africa is also the country with the highest obesity rate in sub-Saharan Africa, with 2/3 of women and 1/3 of men overweight or obese. This goes hand in hand with the fact that 25% of children in the country are undernourished. Social, cultural, environmental, and behavioral factors, including socioeconomic status, are likely to explain this rapid epidemiological transition to increasing obesity in NCD. So another tongue twister there. National Health Insurance, the NHI, and the future role of medical schemes. In June 2018, the Minister of Health simultaneously introduced the NHI and Medical Schemes Amendments Bills. The NHI Bill sought to introduce the NHI into legislation, while the Medical Schemes Amendment Bill aimed to align the current Medical Schemes Act and the NHI. The NHI is a health financing system that is designed to pool funds to provide access to quality, affordable, personal health services for all South Africans based on their health needs, irrespective of their socio-economic status. NHI embraces the goal of UHI and seeks to provide quality health services to all South Africans, ensuring that access to health does not result in catastrophic expenditures. The objectives of UHC are thus threefold: is to ensure equity in access to health services, to ensure that health services are of sufficient quality to improve health, and to protect people against the financial risk that may arise from accessing health services. The NHI Bill creates the legal framework for implementation of NHI and proposes the establishment of the NHI Fund and its governance and advisory structures, which will apply to both public and private health establishments. So a single fund will be created to support the NHI to purchase services for the entire population. The fund will have a tariff setting function. Prices, budgets, and revenue allocation will be determined annually. There will be accreditation, certification, and contracting of service providers by the Office of Health Standards and Compliance, OHSC. A beneficiary registry will be established, and the person seeking health services must be registered as a beneficiary of the fund. The fund must purchase comprehensive health services benefits which are not defined in the bill. Beneficiaries to use their selected general practitioners as primary healthcare providers, where a referral pathway system upstream will need to be adhered to in order to access the NHI benefit. So the NHI seeks to address the deep inequalities entrenched in the South African health system, which see more than 70% of the population without health insurance and are dependent on an overstretched public health sector. So more than 70% of the South African population is without any kind of medical scheme or health insurance. So they solely rely on the government to take care of their health problems. And that is it's a big burden for the South African government costing them a lot of money. So they tried to see if they cannot make another plan to assist them with this. So the second bullet, the successful implementation of the NHI will require a significant overhaul of the system to see a shift in resources to bridge the service delivery gap between the private and the public sectors. The implications for medical schemes are set out in the draft Medical Schemes Amendment Bill. The key aspects of the bill are abolishment of co-payments, so no more co-payments, establishment of the comprehensive services benefits not defined by the bill, which will supersede prescribed minimum benefits, prevention of medical schemes implementation benefit options without the prior approval of the registrar of the council for medical schemes, prohibition of carrying on of the business of a medical scheme by a person not registered as a medical scheme, creation of a central beneficiary and provider registry under the auspices of the Council for Medical Schemes, introduction of income cross-subsidiation in medical schemes through income-related premiums, medical schemes to pass back savings in the form of reduced premiums if a member uses a designated service provider, a DSP, cancellation of membership and waiting periods between joining schemes and assessing benefits. Parliament, Wednesday on 6 December 2023, the National Council of Provinces today passed the National Health Insurance Bill. The bill was passed by the National Assembly on 12 June 2023 and sent to the NCOP for a concurrence. The NCOP, the National Council of Provinces. The bill will also create mechanisms for the equitable, effective and efficient use of the funds, resources to meet the health needs of users and prevent or limit undesirable, unethical and unlawful practices related to the fund. It further seeks to address barriers to access. The bills will now be sent to the President for assent, in other words, to be signed. And this was issued by the Parliament of the Republic of South Africa. The bill suggests that medical schemes will exist alongside the NHI and play a complementary role. The carrying on a medical scheme's business by a person not registered as a medical scheme is prohibited. It may have implications for health insurance products, which likely will cease to exist. So that health insurance products might fall away, but the medical schemes still going to exist. The white paper on NHI indicates full implementation of the NHI by the year 2025. You can learn more about the NHI bill in your books. We are not going to discuss it further on this video. That's the end of Unit 1, Part 3. And after this, we'll have a look at Unit 2. We'll start with Part 1.